Tumors in the superior posterior subdiaphragmatic position of the right liver are difficult to approach surgically or laparoscopically. In addition, percutaneous ablation of these lesions can be difficult due to targeting issues as well as the risk for causing pneumothorax. Thoracoscopic assisted transthoracic transdiaphragmatic ablation is a valuable method for managing early tumors. Presents for this patient is that it would require a complete liver mobilization in order to resect. The dissection would be difficult and potentially morbid in a man with cirrhosis who has had a previous complete mobilization of the liver. This is particularly true if this patient desires future liver transplantation. A solution to this problem is the use of a minimally invasive transthoracic transdiaphragmatic approach to ablate the tumor using microwave. This would reduce the patient's morbidity, preserve his short-term quality of life, and facilitate a rapid return to work. The patient is positioned on the operating room table in the left lateral decubitus position. A double lumen endotracheal tube intubation was performed such that the right lung could be deflated. He was maintained on single lung ventilation during the procedure. Two 5mm trocars are placed into the right chest. One is in the submammary crease in the anterior axillary line through which insufflation to 8 mm of mercury was used to create a pneumothorax. You can see the 5mm videoscope introduce visualizing the inside of the chest. A second trocar is placed in the 7th intercostal space posterior laterally under direct vision, and the pneumothorax was released and the right chest filled with 2 liters of saline. The saline now enables transthoracic ultrasonography to be performed, and as you can see, there is excellent acoustical coupling showing the thoracic space filled with saline, the right hemidiaphragm, and the liver underneath it. The optimal position and trajectory of the ablation needle to the tumor is determined and guided under ultrasound. Once the trajectory is figured out under direct thoracoscopic visualization, the ablation needle is inserted into the right chest and then punctured through the right hemidiaphragm into the tumor, all under ultrasound guidance. Microwave energy is then turned on. In this case, we treated the tumor with 80 watts for 6 minutes. Once the microwave process is completed, the needle is withdrawn under direct thoracoscopic visualization and hemostasis was assured. The saline was then evacuated from the chest and a 24 French chest tube placed and put on suction and then removed 6 hours later. The patient spent 1 night in the hospital because he lived more than 100 miles from the hospital. He was discharged the morning after the procedure and returned to work in 3 days without problems. 6 months after discharge, the patient is doing clinically well. Per our protocol for monitoring patients with hepatomas following resection or ablation, he underwent surveillance CT or MRI every 3 months. 6 months after ablation, he now shows no evidence of disease recurrence and only a hypodense microwave scar. There are several advantages of this transthoracic, transdiaphragmatic approach for ablating liver tumors in segment 7. First, the use of ultrasound has advantages over CT in that it is simpler, avoids radiation, and is cheap. The position and direction of the probe can also be changed quickly, and its position within the tumor can be confirmed in 3 dimensions quickly. Finally, the ablative process can be monitored in real time, and power Doppler can be used to establish complete absence of blood flow as a marker of complete ablation. This video demonstrates that transthoracic, thoracoscopic assisted, transdiaphragmatic approach for ablating early HCC in segment 7 is a good therapeutic option.